Okay, I'm sitting here with Jess Ellis, and we met in Vegas a few years ago.
No, oh yeah,
We did.
Vegas for the Elite Basketball Conference, and we spoke this past year at what is it?
I
Tyler
forget.
Lesher's Elevate. Or
Elevate,
no?
yes. Yeah.
Was it?
Yeah. So I gave talk on tendons, you gave talk on cartilage stuff, and we had some pretty good conversations outside of that. And then we had some patellofemoral conversation I was like, we need to do a show because you're saying a lot of things that I'm not seeing in the research, and I guess we'll get into that today. But this is a Tango and Cash show. You're a guy that knows a lot of movies. Do I need to watch the movie?
Yeah, you do. It's a great 90s flick, Stallone and Kurt Russell. Kurt Russell, long-haired cop, kind of wild, and then you got Tango, Stallone, glasses, buttoned up, and they work as a team. So you got Tendon and Cartilage, and yeah, it's a good movie. You need to see it. You got to be drunk though, or have some inhibition of your brain to watch it.
I've always loved Kurt Russell. Death Proof was
Okay.
I like that movie a lot. I didn't like how the females won. The bad guy lost. That was not good. But you got to tell people who you are. For them
my
that
name's
don't know.
Jess Ellis. I'm a physio by trade. I've been practicing for 16 years. You're from Minnesota. I'm from North Dakota. So very close to you as a neighbor. In the last decade, I've been leadership roles within the New York Knicks and the Portland Trailblazers, and then also at Exos, I was director of PT. Prior to that, I did concierge work with tennis, and prior to that, I was wearing triple pleated khakis and seeing 30 patients a day and hating my life. So that's kind of the evolution of me for my career. I did my PhD on the wearable, the ethics behind wearable technology in the NBA. So to see data rights and how data is being used for and against players.
The ethics. What do you mean?
It's a qualitative study asking a lot of questions about, anytime that you have data on someone, there's a change in power dynamics and there's a conflict of interest. So it's an ethical question at that point. So we put so much emphasis on how valid or reliable are these wearable tech, but there's no studies or anything talking to the tested, the athlete, and their beliefs behind the use of the data. So it was a qualitative study, 15 players interviewed, and kind of looked at the other side.
What did you find?
If you're not utilizing the data in day-to-day and having them as an active participant, there's a lot of mistrust that happens. They don't like sleep data used. If they're going to do it, it should be an independent thing on their behalf, not through the team. There are a few different types of athletes that either like technology or not. So the Ivan Dragos are the ones that want the 1% better. They're the ones that want to get better and use that tech. They're going to be much more engaged, and they're the adopters. The second group are the resistors. That's the big brother group. I don't want anything on me. And then the third group is the optimizers, which is they're compliant with the direction, but it does not take away from their day-to-day activity. And how do you make that as seamless as possible so it's not disruptive? And that's with those three types, you kind of have to do different strategies on how to approach tech in the NBA.
Wow. How did you make it out? Well, I'm actually from Wisconsin, but the biggest city is Minneapolis. So like Minneapolis, I was in Minneapolis because the Milwaukee's further away. Green Bay's not a big city, but they're just further from me than Minneapolis. So Minneapolis has always been the big place I go. How did you break out of North Dakota to end up in the NBA and end up in these roles that you got into?
I hate country music and I don't drive a pickup truck. So those things I left and I went down to Phoenix knowing that that was the highest chance for me to get into pro sports with all the different opportunities. So I married my wife and we moved down there.
And
And then,
now you're back.
yeah, we're in Scottsdale. I have a private space, a lab where I work with athletes. I have a education company called Rehab Code, which thank you for sharing some of my material, but that's where a lot of what I talk about when it comes to a clinical side. And then, yeah, that's kind of my two-headed beast at this point.
Okay. I want to talk on patellofemoral, but we were talking a bit about tendons beforehand. Even at the Elevate, you said some really interesting stuff on tendons. The Achilles Island. What do you mean, the Achilles Island?
So I talk about this because it is the one joint that takes on ground reaction forces immediately. And that's the issue is it takes longer for an Achilles tendinopathy to recover and to get past that acute phase because it cannot hide. So it's an island of itself. Now, patellar tendon, it can be dummy proof. Like it doesn't have to be great rehab or it doesn't have to be great as long as you're loading it to get past that acuity phase and just to get it to respond to certain loads and thresholds. A lot of times they go off and they kind of respond on their own, but they're also hiding between two joints, the glute and the soleus / ankle. But that's the difference is you cannot hide from the forces being administered to the calf complex, which makes that even more problematic and likely one of the reasons why you see more ruptures to that tendon versus a quad or patellar tendon.
Yeah, okay, that makes me think because I've dealing with a little bit of Achilles myself, and then patellar is I can still play basketball and do everything that would load my or patellar without doing it because I just land with stiff knees or I just shield away from knees, bend at my hips. The Achilles, is there not a strategy to avoid? Like people can't do more heel striking or they can't just skip over that foot. You're thinking like you're going to be loading the Achilles if you're going back to
I
sport.
mean, yeah, there are some strategies and some of this is, anecdotal, but I look at the rear foot is the rudder of the foot. So how does that calcaneus look on when it takes on ground reaction forces? And a lot of times what I've noticed is an everted calcaneal position. So there's more loading on the medial side. It's not great for the Achilles complex. There's more traction and loading on that medial side. And it similarly kind of unwinds the subtendon twist that it naturally happens. So sometimes when I train the Achilles, I will twist it from a medial to lateral orientation, either by taping or manual, and have them trained to make sure that I have good vector pull happening on the medial gastroc. Because we know the medial gastroc is likely the most inhibited portion of the calf. I'm trying to get and twist the tissue to then align better. And I use that strategy a lot with Achilles repairs when you're really fighting an altered pulley system that doesn't work the same anymore. The collagen fibers are all over the frickin' place and it doesn't have that natural pull like it once was. And that's why you can't really pull up into end range plantar flexion very well. Sometimes it might be a strength issue, but more importantly, the tendon complex is completely different at this point.
So they're getting more medial stress, or their foot is looking like more everted.
Pes planus. Yep. So more flat footed, more of a everted position and more loading. So if you can get more of an elevation to the medial side, which will put more load on the lateral side of the calcaneus, will have a better orientation to the Achilles.
Yeah.
And then even like playing around with a stiffer sole, which means that pushes the center of mass or the mechanical advantage of the foot further out, can help with improving the mechanics of the calf complex.
You said something at that conference, this whole false step thing. False step people are typically where they're rupturing it in the NBA. Is there research? You were saying this, that when you get older, there's more false steps.
Well, there's more false steps, I think, because it's a strategy to beat the defender at one point in space. And if you A, are older, or B, if you are not athletically built to have that same ability to produce power, you're going to find strategies to create distance and win the strategy. So I find that it is sometimes a strategy used more for individuals that are not as elastic, because they're not able to generate the same amount of pop with a more highly toned or a stiffer complex.
Mm.
So it's more about the game and how you change if you start to get older and you're having to find ways to accelerate, or if you're just naturally not as athletic.
Mm-hmm.
This is 7 years in the NBA, looking at a lot of games, sitting courtside watching stuff. But there are some studies that talk about the mechanism. I'm just talking more from the performance side and why somebody would inherit that type of strategy. You got good memory, dude.
Oh, on certain things. I'm sure we talked about a lot of things that I just forgot. But when you say one thing, it's usually something I think about every day. And I'm like, I was like, I wonder if there was a study on that you were talking about, but it just made me think about it, that it's like,
it's more about a study, not on the mechanism. I mean, it does talk about the mechanism, but it's more about the prevalence of most Achilles ruptures happen at that type of movement. There is some dialogue that talks about, like, you see these individuals that have like a previous calf strain, and then that leads to an Achilles tear. And the thing that I've noticed, or what I've been reading, is there's a combination of a delayed neural firing to the gastroc, and it's the combination of it not firing as quick as it needs to, and then there's a drop in the calcaneus into more dorsiflexion, and then there's that delayed firing. It will fire then, but it's at the moment when it's dropping into that eccentric load to the tendon. So it could be a combination of the tendon itself not being able to take that force, or the inhibition of the gastroc and firing at a delayed as it's moving down into a calcaneal drop.
yeah, I think Colin Griffin, I had him on a long time ago. And I think he was getting at that the calcaneus is dropping, and then that delayed contraction. So it's like the tendon is getting pulled at both ends when it's vulnerable, because the heel, whereas it should have been pulling a bit earlier. And
I mean, it's kind of like if you're rock climbing and you got a spotter. I've never rock climbed, but if you had a spotter that like started to like nod off, and that person dropped, and then they woke up and pulled the rope to like save the person, that's that dropping of the person, and then the quick pull from the guy up top spotting is when it snaps.
With this whole, like, so that presentation with the foot, like that medial, or that more, I guess, flat-footed. Is that proper if I said that?
Yeah.
Flat-footed presentation. I was thinking of this, talking to an Achilles guy the other day, maybe it was yesterday. Yeah, Achilles guy yesterday, college basketball guy. And I was thinking of the subtendons, and I'm like, I wonder if there is a certain presentation, if there's a presentation like that, would you have more, you kind of talked about it, right? Yeah, medial gastroc is probably more like weaker than, so would you have certain sections of the Achilles tendon that are weaker than other sections, and you'd want to bring them up?
I mean, possibly. That's, we can talk about stress shielding. We can talk about the neural aspect of firing. If you look up at the knee, that's the same thing that happens with, AMI, or just a weak quad, is the vastus lateralis will fire at a quicker rate. And what happens is that firing then changes the way that the patella is sustained in the groove of the trochlea. So it's very similar, like these deconditioned or previously injured structures, there can be segmental changes of firing. So yeah, it could change that, and maybe you alter the way that you put your foot so that you can load the medial head more. But that's going into more of the, back in the 2000s when I graduated in 2009, and we were drooling over the ability to fire specific exercises for the VMO. And there's never been research to show that there's specifically things that can fire just the teardrop. So a bunch of nerdy PTs were very, very upset about the inability to find that.
Do you think there is any truth to that? Like certain exercises to people will say bias, they'll quote bias, we're going to bias this certain
I
thing.
don't, I'm not sure. I mean, clearly when you start playing with length tension changes, you can play where you can generate more force. But at that point, if I feel like it's something that's maybe more compartmentalized, then I just really, and it's a compartmentalized and an inhibited area, then I want to put some form of a electric stem to wake that up quicker.
That vastus lateralis, because I had it when I quit college. I went to California, and it was like COVID, so I was lifting heavy, but really no basketball. A lot of the hoops were taken off or they were boarded up in California. I did find some, so I dunk, but I was just like lifting heavy, dunking, just really, I guess, heavy explosive training. That was about it. And I got patellofemoral pain. And then my vastus lateralis, like just sleeping, or maybe it was my IT band, I don't know, just sleeping at night or doing anything, I felt this tone, this really big tone in the vastus lateralis. It was just annoying. And then I think that's contributing to the patellofemoral pain. Maybe if it was pulling the kneecap a little differently.
Yeah.
Is there any truth to something like that?
You're N of one, right? You've just felt it yourself. But that is something I look at. I look at tone. If you're a client of mine or a patient, I would likely do some compartmentalized manual therapy to that area, and heavens forbid that I touch the IT band because it's so strong that why would you ever foam roll it? There's still neural input to that tissue, and there's still that interaction or interface between the vastus lateralis and the IT band. So I do put some merit, either dry needling or soft tissue lengthening massage to that area to help that little bit of, if it's 1 or 2 millimeters at change. Because what we find in the patellofemoral joint, specifically at 10 to 30 degrees, that's not a great range. And the reason is it is a high stress, a low surface area, high concentration of stress to the distal patella. And also, it's not sitting in the cup of the trochlea very well, so it can have a tendency to tilt in that range. So you're telling me that there's not a great location to just put localized stress, and then it can be, maneuvered a bit laterally. That can piss it off.
Mm-hmm.
And I've looked at enough MRIs with NBA players, and their trochlea doesn't look great, but the lateral portion of the trochlea is the thing that shows more wear, which tells me that lateral side is just dropping into more compression, and that is a combination of hip adduction and internal rotation, which causes more pressure to the lateral facet of the patella. And also in baseball, we call the tears of necessity, which is basically, I'm going to throw 98 miles an hour. I need to get my shoulder this far to throw it. And there's going to be changes to the labrum. There will be tears in the labrum. And if you put them in MRI, it's not going to look great, but they're still able to accomplish the task. In basketball, I call it the wears of necessity, which is with time, the trochlea will wear, the patella cartilage will wear. It's not a bad thing. It's just the outcome of thousands and thousands and thousands of jump shots and deceleration points within basketball.
The wears of necessity. Okay. So tendon pain, we don't need to get into. Maybe well, pain is complex, but tendon pain maybe maybe more talked about, more simple. With patellofemoral pain, I've never found a good, because we go to structure and they'll be like, oh, chondromalacia patella is irrelevant because everyone gets chondromalacia patella with age. Patellofemoral pain, we don't know the structural problem. Let's just rehab it. I'm probably somewhat off there, but that's kind of my understanding. What's going on with patellofemoral pain? What is happening?
It's a physics problem. And that is, you got this bone, it's a sesamoid bone, it's a floating bone in a groove. And what is its value? It's one of the most important bones in your body because it creates a change in your moment arm for your quad. And it's stronger and it can generate more force through a longer arc of movement. So as much as it can produce force through that bone, when it's injured or with time of degradation, it also leads to pain. So it's, as much as it's a proponent of function, it's also can be dropped into more of a dysfunctional pattern or a dysfunctional issue. So knowing that, you got to look at it from, it's a dynamic pulley system because it moves within the groove. Now, another hinge joint that we talk about is the tricep. This is the fulcrum, but it does not move. It is a fixed pulley. The knee is special because it glides with arc of movement, which means that joint is engaged through the whole range of motion. You can't hide. Just like the Achilles on Achilles Island, you cannot hide load through the patellofemoral joint. You can with the tendons in some ways, but the engagement and the compression that happens to that bone is always on. So that's where you get the problem. Now, your job is to find where there is improved tolerance to joint angles that can produce force, and then respect the areas that they can. And again, I kind of talk about this stress concentration. So when you're in shallower ranges and when doctors say, don't do the knee extension through, it's going to kill your patellofemoral joint. From 30 to 0, it is a very hot spot. So think of stilettos, like a very pinpoint pressure to the inferior pole and the inferior part of the patella. As you go into mid-range, so 40 to 60, it's going to get better congruency and it's going to drop in the trochlea, and the cartilage behind the kneecap's going to be better to take on force. And then, so think of more of a snowshoe. So you're spreading that force through a longer period of time. And then as you get back to 90, you have a really nice positioning of the patella, but the problem is there's so much force at that point in that range of motion. So if I'm looking at angles that can be problematic to the specific cartilage or the trochlea, it's likely deeper positions at 90 and up, and also early stages or early shallower ranges.
Is that okay? So I talked to Claire Robertson maybe many years ago, and it sounded like the leg extension, like it was that 0 to 30 is like a lot of pressure. Patellofemoral, is that the right
Yes.
term? Patellofemoral pressure, and then when you get like the 40 to 60 is pretty good. When your feet are on the ground, is it like the same, or is it kind of opposite, or what's going on? Like in a squat, I'm thinking.
I mean, that's just, the mechanics may change a bit. I know for a fact with people that have patellofemoral pain, if you do a TKE from 30 to 0, they respond pretty well. So, but I also know people with patellofemoral pain don't do well in a split stance position with the leg being in the back position. And that's because you're at about that 30 degrees of flexion. But the thing is the relation of the hip. Now you have the hip in either neutral or an extension. And now the length tension ratio of that quad is tighter. And now there's going to lead to more compression behind the kneecap. So a lot of times I have to modify that position into more of a Bulgarian with more knee flexion to do different exercises. But the split stance position will be tough. So, for me, it's more about probably deeper ranges in close kinetic chains, so 60 to 90, and kind of playing shallower with close kinetic.
Okay. When you get to 90, so this idea of the pressure is really distributed well behind the patellofemoral joint. Pressure is really well, but the problem then becomes there's a lot of force that you can.
It's the absolute pressure. It's the absolute total amount versus, so it's built to take it on in that orientation and how all those facets kind of fit nicely in the trochlea, but it's the totality of force at that point.
what is the force coming from? The quads?
Compression from the quad and the patellar tendon.
Okay,
Basically,
compression meaning like it's like it's pushing the kneecap down into the groove, or
pushing it into the groove. Yep.
okay, so it's like you have, when you get that idea, you talked about the snowshoe, so like 40 to 60 is like really the snowshoe, a lot of distribution of pressure, and that stays from like the 40 to 60 going to 90, going even deeper. Does that pressure stays as like a snowshoe?
I mean, it starts to narrow a bit again as you go deeper, but instead of it being hit kind of in the distal part of the patella, it's putting more load on the superior or the proximal part. So if you go into more flexion, you're going to be loading the upper portion of the patella and the quad tendon, which is why you see the quad and patellar tendon ratios change with movement.
With the patellofemoral, I guess, where you typically see it, you said you see it more. Where do you see the pathology more? On the underside of the patella, the lateral side, medial side, where is it? Or it just varies?
It varies, but central lateral to the patella and lateral portion of the trochlea is common. The cartilage has about 6 millimeters of cartilage. It has the most cartilage out of any part of your body. So there's a really good bed of cartilage behind the patella, and the trochlea is a very thin layer, so only about 2 millimeters. So there's a variation in difference between those two. But when you look at a lot of MRIs from NBA players, you're going to see that central to lateral, and then I would say inferior portion of the patella.
Okay. So it's more inferior. So you'd think if it is more inferior, if you were squatting deep, you wouldn't be hitting that inferior. You'd be hitting more the superior.
Yes. Yeah.
Yeah. And is that so? Where you find if you look at the MRI and you see where this pathology, what do you term them as? Lesions, or what do you call it?
Yeah, osteochondral defects or a cartilage lesion would be terms that you could use. Mm-hmm. And there's studies that show that you can use cartilage mapping technology on MRIs to see where there's excessive wear or maybe more tendency to load within the knee, and it looks at the water movement and also the proteoglycan interchange of load. And what they find is there's some hot spots that you can start to map on the knee, saying this is an area that is getting more pressure. But the research shows that once it degrades down to a 3 or 4 lesion, which is mean it's getting into a thing called the tide mark, which is a mark on the cartilage where you've basically the last line of defense of cartilage, and now you're in the subchondral bone interface. So when you are looking at MRIs and you see that it's progressed past the tide mark, now we're talking about early signs of OA. But anyway, the T2 signaling and the mapping are more effective early on, like stage 1 or 2. It's a better technology to use as more of a preventative mindset than actually when it's gone past.
Why when it's gone past? Because you can't reclaim anything.
The signaling just gets worse. It's just not as accurate.
Oh, okay. So wherever this lesion is, for when you're looking at these with the NBA guys and you see it's on this certain spot, that lines up. Does it line up with where you're thinking the pressures will be highest when they're moving, and then that's where they get the most pain, and then you try to stay out of them?
Yeah, I mean, I talk about it in a few, like when you saw my talk, it's let the sleeping beast sleep, which is the chondral defect. How do we make sure that it stays like this is aware of a necessity? It has changed and altered the joint, so the rules have changed, but how can we make sure that it doesn't wake up? And that's in itself is really focused in on workload. How much spike acuity wise are they taking on to that knee that could wake it up? And also there are times where you probably would never be able to return an athlete to sport if you asked it to do in isolation things that it just would take too long for it to look good, or they may never look good. And by doing that, you're basically honoring kinematics at that point and not kinetics, and honoring that dysfunction is there, and they will find through the constraints of movements, they will find a way to kind of be successful. So I think we can kind of put our hat on and say we want to make this perfect return to play scenario with proper KPIs. But when you're dealing with something notably like a cartilage lesion, those rules are different. And sometimes it's just graded exposure on the court. And if they're still responding well, they may never look good with a pure isolated knee extension isometric or a isokinetic test. It may take 2 years for it to actually generate enough force that would make them cleared.
So how are you then in, I think you talked about it in your talk, or maybe it was when we were speaking. Was it like a lateral lunge exercise where a lot of people, if you could give that example.
I mean, again, with a lateral, more frontal plane movement, and if you have a central to lateral lesion or sensitivity, you're not going to do well with a lateral lunge. They likely will inherit more of kind of a stiff knee and it just kind of like a hitch where it just doesn't look like clean knee flexion. And that's one movement that I do. If I just have about 20 minutes of time to screen how you look, I'm going to have you do a lateral lunge, body weight, and then I'll have you hold weight and do the same thing. I'm looking at quality of movement, but more importantly, I'm looking at how much trunk flexion are they dropping into to avoid knee flexion.
And is this, like you said, you got to obey the kinematics? If they're not like looking good or they can't like hit this without pain, you're just kind of leaving it alone, or is this something where you're like, we need to? Yeah.
I'm writing stuff down. I'm making observations. I'm talking to the S&C coaches that will be working with them. I'm getting them on the HUMAC norm to look at their isokinetic and their torque curves and know that this is a management scenario and we need to get that curve to climb up. But I'm not sitting looking at somebody saying that I'm going to sit you because you're not generating enough force. Because if it's not reactive and showing a fusion and they're actually able to hoop and play basketball, I've seen Hall of Famers with knees that would make you cringe and they're still putting up 20 points a night, but they can't do very, very basic things in the weight room. So it's just one of those things that if you haven't been in the trenches of pro sports and looking at how true athleticism is and how they find success, and I think out of any athlete, the NBA athlete finds compensation the easiest because most of what they do is they jump from their ankles, not their knees.
So you're thinking that's how they get people like with this bad patellofemoral defects, lesions can still succeed, is just they're just finding ways not to load that certain area of the patellofemoral joint.
And then in season, you manage it by loading it. You are microdosing, you're finding ways to slowly climb that sensitivity, or at least drop the sensitivity to actually load it. Because what you're doing is cartilage doesn't have any nerves at all. What they feel pain is the bone itself. And with time, there will be continual micro cracks, or there could be almost like an osteocyte that kind of gets embedded in between the cartilage and the bone. And it's, that's really a way to strategize and manage fluid. But with time, those micro cracks will stimulate localized healing, and fibroblasts will come in and say, well, we're going to do something about this. They create a callus, which is type 1 collagen, which is your tendons, and they fill the space, and it fills with time. Now you can go to a doc and have them put a drill in and drill through the bone and create this huge bleeding. And then what happens is it's this steroid of healing, basically this huge signal, and now it accelerates. Or you can do it in a more chronic nature with the body naturally doing it. But the problem is hyaline cartilage, I've mentioned in my talks, it's the supermodel of all human tissue, which is, it's beautiful. It cannot be recreated, but it's dumb. And it doesn't know what it's doing. And when you have a change in hyaline cartilage, 80% of it is water, 20% is proteoglycans and chondrocytes. And when you put in fibrocartilage, that water to cellular activity or cellular component is much different. So it does not work as well with the interchange of fluid. And that fluid interchange is called Darcy's Law.
So it's yeah, I'm in the tendon world. It's like I think Keith Barr's talked about that, but well, maybe you get it more at the wraparound regions, the enthesis, however you say it.
Yeah,
more
you
of that,
get more of the cartilage
the
matrix.
type 2 collagen and the proteoglycans are more fluid to be good with the compression, or to handle compression. But when you go to like the cartilage, that's all it is for is compression, right?
Well, the cartilage has two roles. It has compression to take on ground reaction forces and gravity, and to create the most frictionless environment between two joint surfaces. So one is shearing, and one is basically taking on load, and it's a internal pressurization system of hydrostatic pressure. And we can talk about kind of the temporal nature of the viscoelasticity of cartilage, which is if you have high force or high strain, there's going to be, it's a rate dependent issue where now the water content can't get squeezed out from the sponge. So it takes all that pressure from the internal structure of the matrix and absorbs force. And if it's a slower application, so it's very similar to a tendon, a slower application of load, it uses efflux or removal of fluid through the matrix. It pushes out into the joint, and then that spikes hydrostatic pressure. So a lot of the load is being taken on from this really stiff water balloon of fluid, and not so much the interfaces of the cartilage itself. Because when we think of fluid in the knee, we need to go into Newton's law of fluid dynamics, and synovial fluid is a different type of fluid because it has viscosity and it changes with stress. And that's why it's a non-Newtonian fluid, which it does not abide by Isaac Newton's laws of fluid. It is just like paint. If I take a paintbrush and it's thick, that viscosity is high. The moment I start to spread it with speed on the wall, it thins. And that's what happens with that interchange of fluid within the knee. When you sit for a long time, it becomes very cushion and thick. And that requires you to get the knee moving and create heat and shearing, which then will thin it out, and it spreads between the two the interfaces of the joint.
So what does this viscosity mean when from like I think we had talked earlier, you were telling me about some things you do for someone with the patellofemoral pain, with like speeds of movement, with holds. Because when it comes to a tendon, it's like, okay, the viscoelasticity is just like, if you move fast, it's an elastic, stiffens up, it's elastic. When you move slow, you get this like fluid movement to come out of the tendon. You get things kind of shuffle around in the tendon, more of like a health effect. What's going on with the patellofemoral joint with speeds of movement?
So again, we have two roles of cartilage: compression and this exchange of micronutrients with loading and unloading. And then we have shearing and how these two have frictionless environment. So when I want to create more reduction of shearing, this is when we start to talk about something that I've been talking for the last year, which is a principle by Bernoulli, who was a physicist from the 1700s, who wrote a book called Hydrodynamica. And if you and me ever want to start a cover band, like a Metallica cover band, I think it should be called Hydrodynamica, because that's just an odd name. But what he found was there is an inverse relationship of pressure and velocity. So if you have a higher amount of pressure, you have less velocity for the fluid to glide through the joint. And vice versa. If the pressure drops, there's more fluid. So if you go and ask somebody to just start doing isometrics, either overcoming or yielding without good preparation, you're asking it to do a high pressurization movement when knowing that you have a pathology of the knee, it needs to have additional work to coat and get it prepared to do it, to create that frictionless environment. So what I talk about is the Bernoulli prep, which is doing velocity-based movements first to get that shear thinning fluid to kind of coat the whole complex. And then with graded exposure, you start with high velocity, low pressure, and every stage you get more pressure to the knee. So you start out either on the bike, or if you do knee extensions with very low weight and just speed and just kind of get this fluid to kind of move through the knee, maybe some banded TKs for speed with light load. That's your first stage. Then the second stage is I like to share the load between the glute and the knee itself. So I find almost a coupling, sharing movement, maybe even more glute dominant, but you're starting to sneak in some loading through the knee. So that'd be like a high step up on a box where it's more of a glute derived movement. Or maybe I have them do some form of, a goblet squat or a front leg elevated split stance where it's glute and knee working together, but it's a little bit more glute specific. And then I transition into pressurization, which is I'm going to do some form of isometric loading, whatever feels appropriate for that person. And then after the isometric loading, I go into some form of eccentric loading. And then I end it with plyometrics to basically prepare that joint to take on rate. And when you do that, if you do it enough, knowing that you have a management scenario with this knee, if you see them one day and they're able to go through it with no issues, and then you see them in 2 days and they can't get past the second stage without it being sore, you already know that the knee is starting to respond in a way that you don't want it to. And that's the problem with some of these knees, is that they become so chronic. It's like chronic pain. They've lived with it for so long. They're not very good at being a historian of how to manage the knee, and they can be their own worst enemies. So with creating kind of this graded exposure prep prior to you having them do sport or do like a training session, they start to understand how the knee is responding to load, and you can make adjustments from there.
Okay, that first part, doing the high velocity to coat the knee, because when you have the patellofemoral pain, is there less fluid, or what is it?
Well, a lot of times when you have a cartilage problem, you have more fluid. You have kind of like resting residual effusion. And then when you have resting effusion, it increases the hydrostatic pressure of the knee. When you have more pressure, you have less velocity. So if you have a underlying swollen knee that constantly just it's not a dry knee is what we call it when there's no fluid. That's what we try to strive for. If there's residual fluid, that already changes the pressure at the start point. So you're already dealing with increased pressure. Again, that means that fluid exchange is going to be slower.
With the tendons, because there's that work with Lauren Pringles on the pathological tendons having more of the proteoglycans, glycosaminoglycans, of fluid, and then you want to squeeze it out. And I've kind of looked at it. I think he's talked about this too recently, the pressure but he says pressure and perfusion. Is this a similar line of thought? So like the tendon is naturally like high pressure. So like you don't have much perfusion. Maybe this is blood flow. You have lower perfusion, exchange of nutrients because the pressure is so high in a tendon. But then when you get pathology, well, actually, now this doesn't completely make sense to me. But anyways, for you, how are you looking at is there a difference with tendons, or are they the same as cartilage in terms of this pressure and fluid when there is like a pathology in each of the structures?
Uh, I think when you have a engorged tendon, it's going to be more painful and you want to squeeze that fluid out. I think for the cartilage, it's the fluid outside of the matrix. And if that is high, then you don't have that good sponge. We call it cartilage breathing, which is when you compress, it squeezes out. And then when you unload, it draws back in. And that's how the cartilage breathes, and it creates micronutrient movement. But if you already have a high amount of fluid externally to the cartilage, that interchange of micronutrients is reduced. So
Okay.
your case, the hydrostatic pressure is higher in the tendon. The cartilage, it's probably more outside of the cartilage, and it's not allowing that nice fluid exchange.
Okay. Yeah. Yeah. So the cartilage is the thing that should have this fluid in it.
Yeah. It's
Yeah.
just there's a backup of pressure so it's critical to get the knee with no effusion, and that's going to allow that quad to fire better. You're going to be able to glide through with the patellofemoral joint with more efficiency. And again, that fluid exchange is better.
And the weights for the tendon, because the tendon takes on fluid, is like just do an isometric, like a heavy isometric, and the fluid squeezes out. But with the patellofemoral, if you just go into the heavy isometric, you could actually make it worse. You didn't take care of anything. That's where you're looking at the high velocity stuff.
Yeah, yeah. And then even when introducing more of the pressure specific work, like when we're talking about that subchondral and bone interface, it's not a cartilage issue. It's something beneath that. It's a desensitization. It's a graded exposure. And how much are you going to dial and pull the levers to say, I'm going to load that, and at what magnitude? And I've talked about this with my talk and even on some of my social media, but the Pepe Le Pew. And the Pepe Le Pew is just like the cartoon. He's kissing the gal and he's doing small pecs. So it's, high frequency, low intensity or low to moderate intensity, and low duration. So your isometric load would be 30 to 50%. Your one we're at max or tolerance, and you're doing it for 5 to 10 seconds maximum, and you're doing it frequently throughout the day. Within maybe a 6-hour frame, you're hitting it multiple times in the day, but you're just trying to hit the callus. You're just trying to engage that area to desensitize it, to create that interchange of fluid, to get some of that cellular activity to start building, again, that fibrocartilage that's not perfect, but it's something. And that's much different. You're going to smoke a lot of your patients with patellofemoral pain by doing the opposite, which is the tendon, is like you're making out with someone. Like it's high intensity, high duration, and you don't do it very often. So that's the opposite.
Yeah. Okay. This was one thing I remember you saying, and it was kind of conflicting with, well, I guess just advice from other people in the patellofemoral space, which maybe can be, it's more like maybe more the people that have a really flared up patellofemoral joint, and you try some loading and it just pisses it off. So they'll be like, okay, we'll load you every third day or every fourth day or every fifth day, maybe. But what you're getting at is like multiple times a day, this type of loading, and it's trying to get this, I kind of think of myself where I'm like, I've had patellofemoral pain many times in my life. And if I just do nothing, it does not get better. Like with the tendon, if I flare up the tendon, I can kind of rest and it will get better after day. And then I can go back to sports and I'll sometimes be good. Now, if it's a chronic tendon pain, it's like, I got to address all the deficits. But if it's just an acute flare up, goes away in a few days, I'm back to 100% in no time. With patellofemoral pain, it's never necessarily been like that. I don't know if you could look long term with people if they just rest with patellofemoral pain, and if we're talking about this bone desensitization, is that not going to happen? You're not going to get this kind of like scarring over this you need to get this scarring over, this touching of the callus frequently. Yeah.
I feel like for one thing, if with the Pepe Le Pew, like I'm not going to do this strategy if this joint is hot and it's irritable. I'm just offloading. I'm getting them on a bike. I'm having them wear a compression sleeve. I'm just trying to clean out anything that's residually, or if there is bone marrow edema driving into the bone, like I want to get out of that. Maybe some anti-inflammatories. And then as that subsides, then you can start to condition the patellofemoral joint with loading. Maybe you start in angles that are more tolerable, and that's where we start. And again, you're kissing the lesion and you're off, but maybe it's in where the contact pressure is more dispersed and not localized to the area. And as they respond to that, then you can kind of say, we're going to encroach and go into the spot that's more challenging. But again, it's always that low intensity, low time, and then frequently throughout the day to just stimulate it. But yeah, it has to get out of that anti-inflammatory phase. And the other thing is patellofemoral joint, it may take some time, but then we forget about it and then you just move on with your life and then you piss it off again because you do need seated knee extensions and you weren't really focused and it's now awake. And it may take 2 weeks, but that's the other issue about this whole thing is sometimes it's very easily forgotten because it just kind of gets better on its own.
Mm. Why not higher duration? Why not the higher duration hold? Why do you want to do this? Like 30, you said 30 to 50% hold for a few seconds, just like, I guess, yeah. Why not hold for a longer duration?
I mean, the patients don't read our textbooks. That's number one. Context is king. Like I can say something in absolute and you do something opposite and it's better. Like you need to take in to effect every patient is different. But if there's a principle or if there's something you need to explore initially, start there. And if they respond well, then great. Load it for a longer period of time. I would say with a cartilage issue, probably start with more durational changes than magnitude. And I think that would be different with tendons. So you're still changing the principle. So you may stay with the intensity of contraction, but hold it longer. So that would be the first thing that I would start to adjust once the knee is responding well. But that last bit, when you're producing high force, high rate, that's again, when we talk about Darcy's law in the exchange of the temporal reaction to stress, that's where you're challenging more of the internal pressure of the matrix because it doesn't have enough time to exchange the fluid and prepare to have it more of a natural increase in hydrostatic pressure of the entire knee. So that's why magnitude and intensity is pushed a bit longer.
Mm.
And the other thing is time is much, I think you have to have a discussion with your client or patient that it's going to take longer than a tendinopathy.
Why do you think they tend to take longer?
Because we're dealing with the supermodel of tissues. We're not dealing with, they're the divas or the divos. They're the ones that it takes longer. And it's because there's so much stress and pressure that happens behind the patellofemoral joint. And again, it is a dynamic pulley where it's engaged through full range. It cannot hide.
Biking. What's your idea behind having biking for some of this patellofemoral prep?
Biking's okay. It's just the amount of resistance. I look at biking as a functional range of motion and kind of this compression offloading through range to pump. It's more of a pumping mechanism. But for higher resistance, it's probably not great because you're in those deeper pressure points of the patellofemoral joint. Once you get into that 90 degrees, that's higher pressure.
Mm-hmm. But generally doing as like a warm up, lower resistance.
That's great.
It's gonna, it's gonna help. What exactly in your head is it helping?
I mean, it's it's internally warming up the tissue. It's warming up the synovial fluid. And old guys, when their knee hurts, what do? They go grab a heat pack and they throw it on their knee, and miraculously it starts feeling a little bit better. And we don't, this could be another talk, but heat shock proteins within tendons and also the cartilage, they start to wake up at 102 to 106 degrees Fahrenheit. If you put it on for 20 minutes, 15, 20 minutes, it starts to wake up the cellular activity to kind of like clean up some of the debris and some of the kind of the metabolites that are just kind of stagnant. So heat is helpful. You just got to look at what your dad does.
Okay. You have this your sequence there, that high velocity thing. And then, you're kind of doing something to pair the glutes and the knee, that next thing. And then, some form of isometric loading. Then you go into some eccentric. What's your idea behind doing eccentric loading?
I want to get that joint to start to glide through the trochlea. And when I say eccentric, I'm going, submaximal. Like I just don't want it just to be specifically a yielding or overcoming hold. I want through range to kind of get through that whole range of motion, that range of joint congruency through the whole knee. And I just prefer eccentric over concentric.
Okay. And then, like your last one, you said you go into some plyometrics. What type of?
Probably more extensive and absorption versus, higher ground contact time, stiffer landings. Again, that's that Darcy's law that I'm trying to manage. So it's probably more absorption in nature and acceptance of force.
And this was something. So how did you how many this sequence you have here? Yeah. How'd you come up with this? It's just trial and error?
Trial and error, dude. Like just seeing enough NBA players with bad looking knees and they're still playing basketball. And how are you strategizing in the weight room that they're still loading the knee respectively? And the fact is, being the person that kind of brought isokinetics back into the league. Like I was in a phase when they were more used as a laundry coat hanger than anything. I actually purchased a brand new one and I kind of created the new wave, and now there's a lot of teams that use it. And I chose to use it because I was using other ways to test knees and they were, using hip strategies or doing things that were kind of not allowing me to make a better clinical decision to front office to say this guy is good to sign or not, because I had all the MRIs in the world to look at, but I didn't have a good functional benchmark. So getting isokinetics, now I started to marry force production or torque curve related to pathology and seeing how it responded. And by getting that information, then we started to adjust what the guys did in the weight room to try to address some of these issues, even though that they were pain-free.
Was there
they weren't pain-free. They were just hiding the way that they played basketball.
Mm-hmm. Were there things on the court that were really pissing off patellofemoral joints?
I mean, deceleration load. So if you look at the decel ratio, if you have a low ratio, that means there's a higher amount of decels. That's one of the first things I look at. Players that have a high risk, or they may start to show some reactive effusion. That's one of the metrics I look at. And mechanical intensity as well.
When it's so you kind of have this isokinetics. What is this? I don't know what you're talking about.
What is this thing you speak of?
Yeah.
So isokinetics is basically equal speed. That's what that word means, which means I'm setting a specific speed that you have to push through a bar, basically a knee extension machine, and I'm not allowing you to push any faster than I've asked it. So many times we test at 60 degrees per second. It's a nice profile of how much force that you can produce. But you can also, it's better than doing an isometric test because you actually see the torque curve of how strong they are. And with, again, the patella creating a longer arc of movement for the moment arm, you're strongest at about 50 to 70 degrees. And you want to see how high that peak is, but then also, are there any areas within the curve where there's torque decay? And if there's torque decay, that means it's not accepting load through one part of movement. And if you can find that, then you can start to load it in the weight room, or you can get on the HUMAC or whatever isokinetic company you use, and you can train it. But it's basically, it allows you to see a full expression of force through an arc of movement, and it's isolated to the extensor mechanism.
Okay. And when you have that, an area of decay or an area that they just can't, this is what you're thinking is this is the lesion like communicating to the nervous system and then shutting off the quads, basically.
That's an inhibition. Yep. That's just saying I can't produce force. It's harmful. And then it finds way to produce force later or earlier in the curve.
Mm-hmm. So in the research with like patellar tendons, the thing is like they'll have the stiff knee strategy, stiff landing strategy. With patellofemoral, I don't think I saw that. I think I saw more like what was the commonality in the research with someone with patellofemoral pain? Was it like their knees cave in?
Yeah.
Or they just don't?
Yeah, I don't know on that. I do know that, like, if you're looking at the curve, there'll probably be a drop in force around that 30 degrees. Again, that's a mechanical disadvantage to the quad. It's not very strong in that position, but it'll likely be kind of a low hill from about 30 to 60, and then likely build up after 60.
I think I remember in your talk, an injections.
Yeah.
What are these for the patellofemoral joint?
So when you're looking at the hydrostatic pressure and the fluid, when you're having a struggling knee, the body senses that it's struggling. So what fluid's in the knee is called synovial fluid, and the main ingredient to synovial fluid is hyaluronic acid, so HA. And that is the mechanism or ingredient that helps with thixotrophy, which is a changing of thickness of the fluid to do its coating. But the issue is as you start to have a failing interface or inner surface of the joint, the body knows that and it'll start to dump more interstitial fluid to help. But the issue is it doesn't have hyaluronic acid. So you're diluting the concentration of HA. So you're just putting more fluid and it's increasing pressure, but it doesn't have any of the good stuff that helps with coating. So the example I say is in high school, I drank, I'm no angel, and I stole alcohol from my parents. I'd take a bottle of vodka, I'd make a mark where the vodka was, I'd pour it in my Coke bottle, and then I'd put the bottle underneath the faucet, I'd fill it back up to the line, I'd put it back in the cabinet. Now you have diluted vodka, you have diluted HA. So now when you get the injection, like a monovisc, which is it's a large amount of HA, it helps with lubrication. You're trying to improve the concentration gradient of that fluid that's in the knee, which then will help with coating between the surfaces. So if somebody has a cartilage issue, ideally getting them on 2 to 3 times a year with a HA injection might be good for them.
Because your body can't do it itself.
Yeah, it's not sending the right stuff. And really, again, what we talked about, they're dropping more fluid, it's creating more pressure. And then with more pressure, shit happens. It can't find a way to manage the effusion. So what happens is your fat pad likely gets engorged with fluid, and then you start to get recesses or what we call a Baker cyst in the back of the knee. And it's a one-way valve, and you start to get fluid pushed in the back of the knee, and it can't come back out. And now you have this fluid-filled cyst in the back of the knee.
Okay, yeah. When I go to I have that SpongeBob analogy for the tendons. They swell up, but it's like hard to see.
It's the inverse.
Hard to see. Okay, yeah. I was gonna say, but I was gonna say on to the naked eye, because like someone has a tendon that's, and I'm like, I don't think you can see it to the naked eye. With the knee though, the patellofemoral joint, you can actually see this effusion.
Yeah, I mean, you need to track it. That's one thing I teach my patients. Like every morning, your audits are you look at if you have any bogginess or any kind of puffiness in the knee. That's one check. Second check is you do range of motion. So if you have full extension and if you have a Baker cyst, it's not going to like that because it pushes fluid in the back of the knee. So you'll start to feel stiff with extension, or vice versa. If you put them in end range flexion, they're going to put more pressure on the suprapatellar pouch, which is the pouch just above the patella, and then they'll feel stiff there. So that's a morning audit check of, does it look puffy and what's your range? Does it feel stiff? If I get that information and they come in, then I know that the knee might be waking up, because a lot of times pain is not the first thing that comes. It's the effusion.
The beast is waking up.
Yes. Yep.
Okay, I did a show with Matt Watson. He talks about thixotropy, whatever. I've actually never heard of that term. Can you explain that a bit more?
I mean, thixotrophy is related to a French physicist named Hagen Poisson. You don't need to try to spell that. And it's just the relationship of what I talked about with the viscosity of fluid and how it changes with force, and it starts to thin as you apply more rate or force to it. It starts to thin, just like paint, or just like if you had honey and you would start to stir honey with speed, it would start to loosen up.
Yeah. Okay. There are things in the patellofemoral pain world. One of them is the taping, and like some people get results from taping. Is this something you've used? What are you thinking is happening when you?
I mean,
like the diamond taping, McConnell taping. Yeah.
yeah, I mean, if you're going to do taping, I probably would try to offload the lateral facet, so pulling it more central, because we know, again, 30 degrees is not great, and that's also a position, almost a loose pack position, where the kneecap can shift. And again, if you have fluid behind the knee, that can shift even more. So gliding it more medial to get it more centralized is good. And then, have you seen individuals with tennis elbow and they wear those show part
Yeah.
straps, right? So what happens is, ow, that hurts. I'm going to put a strap here. As forces come through the forearm, it hits the strap first, dissipates force, and then it doesn't hit as much on the origin site of the common extensor. Now you flip that to the knee, right? If you put pre-wrap and roll it up to the inferior pole, as force comes up through the tendon, it hits that pressure point first, and then hopefully it dissipates force away from the irritable tendon. So that is another strategy of taping, is supporting the patellar tendon. It probably wouldn't be more for patellofemoral joint. It likely for patellar tendinopathy, but I would at least explore if that helped.
Okay, I have a bunch of YouTube videos on patellar tendon. One of them was on getting the quad strong, getting the knee stronger, but then like loading the knee. And then I was like, but there are strategies to offload the knee if you get better ankles, calves, if you get better hips, glutes. When you're looking at people with patellofemoral pain, I think in the research they were like calf training can help, hip training can help. Do you think, not getting at like root cause type things of like, does someone present with a strategy that just overloads the knees, but more like a thorough rehab plan? Do you think there's actually, you said D cell is like the big one for patellofemoral pain, but you can't, how do you hide, can you offload a D cell? I guess if you bent more at the trunk.
Yeah, you can, it just requires the impulse. If you have a longer impulse, you have a longer time to accomplish the strategy. But when you cut that strategy time in half, you can't inherit that. So you either injure yourself, you fall over, or you take 4 more steps.
Yeah. Yeah.
So it's one of those. But here's the thing, like the world that, I'm getting old. I've been in the profession long enough. Now I'm going to start talking about other shit that's not as relevant. But like back in the early 2000s, like we talked a lot about the hip for knee pain and making sure glute med and the lateral hip musculature is important. And we, like we always do in our profession, we just blinders on that and we just do that. So a bunch of patients had knee pain that just started to get hip strength and they still left PT with a shitty quad because it wasn't addressed, but they had a great glute. Now, as we've transitioned, now we've gone into the other world of like isolation. Let's get handheld dynamometry. Let's get our force profile. Let's get the quad stronger. And it's like, well, how about the knee or the patellofemoral joint has failed because they're not using strategies to use their hip or their ankle. And that's the causation of their crappy kinematics. So again, now we got to get the pendulum to the other side and respect the kinetic chain. It is very cringeworthy to say that because we've used that term way too much in very ambiguous ways with no real methodology. But I do think, yeah, you got to look at the glute strength. You got to look at soleus. If you have a deconditioned soleus, it is the airbag to the knee. It takes on force first. And if you can dissipate enough force from the ankle, then the knee's like, they're doing great. They got a roommate that's paying rent on time. They're not that shitty. I'm going to get you in 2 months. And now the knee is paying for rent because the soleus isn't doing the job.
I've never heard of there's a study on the fat pad being the airbag of the knee. I've never heard of the soleus as the airbag of the knee.
The fat pad is the barometer of the knee. So there's been a longitudinal 96-month study to show that if the fat pad shows hyperechoic or hypo, so at least some fibrotic changes or some excessive inflammation to that area, that there will be cartilage pathology in your future. So I call it the barometer because it tells you how healthy your knee is because stuff gets dumped into that area.
What is the point? What is the point of us having that? I mean, we have fat pads all over, but the infrapatellar.
The fat pad is a way that you manage friction behind the tendon. It is a way to buffer forces. That's why you have fat pads. They're like brake pads. And when we look at the patellar tendon, most of the damage is on the posterior band of the patella because not only is it dealing with tensile forces, it's dealing with compressive forces as well. So now you have this bony interface that starts to create damage because it's the weakest link of the tendon. And now you're going this ultra stiff anterior band of the patellar tendon and this degeneration to the the posterior band. And it's the combination of compression and tensile.
If you say if you see these changes on the fat pad, this patellofemoral problems are probably coming about. If I did a couple shows with Jill Cook years ago on like the differences patellar tendon and patellofemoral. When you're looking at these MRIs of these lesions of patellofemoral joints, if they have these fat pad changes, do they also have tendon changes? Are these all going on at the same time, or?
Yeah, I mean, it is a joint that's losing the battle. So you're likely having tendopathic changes. You're likely having high signaling to the fat pad. The research shows that there's not a lot of hypoechoic findings where it's more of like a fibrotic or stiff fat pad. Most of the studies show it's more of this engorged, inflamed fat pad where there's more fluid. So, yeah, I mean, they're neighbors. Like it's going to happen.
Mm-hmm. What the soleus? You said if it's deconditioned, you're gonna get this more of this knee stress. How are you determining that?
How do I test it, or how do I determine the mechanism?
Both. Yeah,
I mean,
yeah.
if you're decelerating, and if you're not decelerating with a more plantar flex position, let's say you're landing more midfoot, you've just changed the moment arm of the ankle. You're asking it now to stop the same rate at half the distance. So that's the issue. Deceleration needs to have torso back, foot in plantar flexion, giving it enough time to plant and then let tibia transition forward. The moment you start landing midfoot, that airbag can't respond as well. And if anybody doesn't know what I'm saying, I'm from North Dakota, and it's airbag.
That was a big thing when I moved to Ohio. I said sandbag, and everyone's like, "What did you just say?" And I'm like,
Yeah.
"Sandbag." And
So,
yeah,
so yeah, the foot position is important because it's going to really challenge the ankle if it's a mid stance, or it hits that midfoot too early, because then it just doesn't have enough time. So it could be just positional or reactionary. That's an issue. And again, if you're dealing with an Achilles issue, let's say an Achilles or an Achilles repair, it does not like end range plantar flexion. That's why you see a lot of contralateral, or if you have someone that has an Achilles repair, sometimes they tear their ACL, or vice versa. The ACL, they don't have a strong enough quad, they overuse their calf and they tear their Achilles. There's such a good relationship between the two, but if you are not having that negative torso angle with a plantar flex, and now knowing that the Achilles repair isn't strong in that position, it's going to transition quicker out of that range. And now the quad has to do more because the ankle didn't do it the first, through their plantar flexors. And Eric, my friend Eric Mayer, talks about, a deconditioned knee, the soleus becomes the predominant decelerator. It becomes the body's knee extensor, and it's influencing knee extension through the ankle.
The big when I've had patellofemoral, I had it. One time I had it real bad. I was dunking every day, but I worked at a gym in Minneapolis, and we did band resisted sprints, you know? So I had to hold the band behind a guy while he's sprinting. And then, when he finishes, I have to decel, and it takes me like 20 steps to decel because it hurts so bad. But this feeding into, there was this study, I think Baxter, and then I don't know his first name, Josh maybe, Carl and Silvernagel, loading index. They had study on loading index of patellar tendon, patellofemoral joint. One that stood out to me was the Spanish squat. It was like a ton of patellofemoral joint. And I've had people try Spanish squats with patellofemoral, and usually kind of, well, it depends, but a few people it's really blown it up. What do you make of a study like that? So for like patellar tendon, they had their own mathematical way with like the impulse and the rate and other things. With the tendon, it was kind of useful for me because I'm like, this does kind of line up with what I think someone's gonna get in more pain as you increase the speed, as you increase demand on the quads. But with patellofemoral joint, I was like, I don't know if you could just go down this list of like walking is low and then all these things, and then do you think there's a way to like, would that be useful, I guess, after this whole talk of what the complexity of the patellofemoral joint? Could you have a loading index scale similar to a tendon, or is it like, what are you thinking?
I mean, again, it matters on the synovitis or the chondral lesion, or at least the area that is overly sensitized, is likely related to the joint angle and how that relationship of surface area of pressure behind the kneecap. So like we said, at 90, there's a huge spike in absolute compressive forces at that point. though you have the best position for the facets of the patella to sit in the cup of the trochlea, it's still the highest position for that joint. So I think your index, because I know the index is really, the decline single leg squat is the worst. Like, so that was a great study. I just think for patellofemoral joint, it's very unique, and you don't almost have to look at like joint specific positions to get a better understanding.
Hmm. You said in your talk about Seidman. Seidman might be right, 90 degrees. Was that what you were saying, or what was it?
I don't remember. I'm not sure on that one.
I thought you was talking about Seidman, and you were talking about the patellofemoral joint, and because he was like,
he's not past 90.
Yeah, deeper than 90. No
Yeah.
good. I thought you had something you were talking on that. No.
I jokingly said it because it was, he's the anti-parallel man. So in this case, that might be work. That's partial arc of movement away from the highest pressurization of the knee, behind the kneecap. And even the condyles. Like, the further you go down into flexion for a condylar lesion, the more you're going to engage the posterior portion of it.
So this thing, I think back when I first got my patellar tendon pain, which was just, I guess, but they were watching my kneecap, and they're like, "Oh, it is tracking laterally when I bend, and I need to work the VMO, whatever idea they had." Yeah, is there any stock to put into patellar tracking?
I mean, there's a few biomechanical things that can change the way it sits in the groove. One is trochlear dysplasia, or a shallow angle of the trochlea. If it doesn't have a nice depth to it, you're more likely to dislocate your knee, and you're not going to load it very well through the trochlea. Number two is the patella alta. Patella alta is a tall patella, which means it sits tall, which means it doesn't fit great early in 0 to 30. And something we looked at for our MBA guys was, we at least put some level of concern if they had patella alta, because there probably might have some issues with patellofemoral joint issues in the future. And when we talk about OCD lesions and what's the worst of the worst, trochlear lesions that don't respond well to load are the worst ones to deal with, and the surgical outcomes are the worst as well, versus more of a weight-bearing lesion on the medial femoral condyle or lateral femoral condyle. So looking prognostically at maybe a headache, we looked at patella alta. How high does it sit? So yeah, and then that lateral tilt, it sometimes can sit more on that lateral side. So yeah, they probably were trying to address getting you to offload the lateral facet.
But if you have the shallow groove, what do you do about
it? Call your mom and dad and ask why. Females are more victim to this. And yeah, they're the ones that have the classic dislocation history or subluxation.
And then patella alta, the only thing is that there's that surgery to bring it down, right? If it's bad enough, yeah.
Yep.
Yeah.
I mean, the other thing is we call it a Q angle, but if your tibia is externally rotated too much, it then puts more of a vector pull on the lateral side, which again would address that lateral facet.
Is that okay? That tibial rotation. I had this was a few months ago. I just do phone consult, and a guy patellofemoral pain. Just posted on my Instagram about tips for patellofemoral pain. I think I probably got like 50 good replies. A few of them though were on that tibial, like the tibia being quote unquote stuck or in the external rotation. Is that something that you see someone with patellofemoral pain presenting more?
I mean, I mean, you just have to train the knee. We only look at it as a hinge joint, but it's a modified hinge joint, which means it has transverse movement capabilities. And if you can get the knee to just rotate 1 millimeter more medially, that can help clean up some of the tracking issues or some of the, compression issues that you're dealing with. So it's for sure, you got one of two planes to deal with, and we just focus on sagittal plane, flexion extension. And yeah, you need to address rotatory movement, even frontal plane. I look at that, how much can it glide medially or laterally, but that's a little bit more when it comes to weight-bearing lesions on the condyles.
How do you get that tibia to inside rotate?
PNF, getting them to having your hands and having them learn how to rotate into internal rotation. And then when you have them, you can have them do like a not a long sit, but, basically sitting, and have them go into extension, but then bias into external rotation at the end, which is basically working on terminal knee extension and the, basically the screw home mechanism to lock it. And then to unlock it, you're going to do popliteus. So you're going to bring the ankle inward and go into flexion and work that range the whole time with the foot in an internal angle. And then you're going to go back up into extension. You're going to try to press out into external and then go back into flexion with internal. So you're getting the sagittal movement, but you're doing some combined rotatory, and you're trying to clean up the joint to see if the knee can do that transverse movement qualities.
This research, I don't know if it's in research. Enda King, I did a show with Enda King on patellar tendons, and I asked him about the biopsychosocial element, and he was thinking that it's probably more, or the psychosocial is probably more of a thing in the patellofemoral cases.
Yes.
Yeah. What are your, why do you think this is the case? Because
Because it's likely chronic. It's likely frustrating because they've slowly with time, their function has regressed in a way that they can't, they're not dealing well with it. The pain patterning is a little bit more odd. It's more diffuse. So yeah, I just think it's more influentially gonna start to influence your day-to-day life. And sometimes when you try to get back into the functional thing after time and it just continues to wake up and you're just not able to respond, that's not great mentally. You start to lose confidence. You start to gain more fear avoidance behavior. Now you say, I can't, I'm 40. I can't chase my kids anymore because my knee blows up. The other thing is it behaves in a way that it reacts, and there's a fusion, and that's not a great feeling either, that you wake up one morning and what you thought was not much, now you got a swollen knee.
With a lot of my my phone calls, I ask if they got imaging for their tendons or for their patellofemoral, just because, and then if it's chronic, maybe it's like, maybe you need to get some, you can see what's going on in there. Is this something you like to see with patellofemoral? Is an MRI to know what's going on? Or yeah.
I mean, back in the day, I would never want to look at MRIs because I was so much a functionalist. And now I'm talking to you for a while now on structure. So I think we've tipped the hat that structure is everything. It changes the way that the body will, choose strategies. I look at, I hate this term, the bridge between rehab and performance, right? It's just too much. We've said it too many times. But if we traverse through the gap of rehab to performance, the thing that lies in the middle that makes all the rules is pathomechanics and pathology. That is the bridge. Because if you're healthy, you don't have to deal with it. performance and everything is nice, but when structure changes, the rules change. And I think that's the number one piece about this whole thing is that's why patellofemoral joint issues are so complicated and frustrating and have, again, psychosocial tied into it, is the rules have completely changed and now you have to behave differently and it takes longer than you would expect. And you have to do low intensity, low durational holds frequently throughout the day. And it takes time. And you have to do strategies to get the knee warmed up before you go do things. And people don't want to inherit those strategies. They just want to go do their sport or do their hobby.
How do you think these are being mismanaged out there? What are the things? Yeah.
I think cookie cutter loading strategies and protocols that just don't match, not honoring the irritability and severity of the knee to kind of push through pain to get through it. I think it's sloppy. Not looking at the whole body and the responsiveness to getting more glute and hamstring and calf and kind of exploring the whole thing. Changing the rules, saying that isometric loading's not great. How do we do other things to load it? And kind of getting off that stubborn clinical view of we have to do this. We have to do 30-second holds or 20-second holds from a overcoming isometric and train it that way. So I think it's more of the subjectivity of each person's pain experience and how do you adjust to it.
What is the end of, so when we talk about the structural problems, I guess if you look at a tendon, although you do get really bad looking tendons, but the end of it, I guess, would be you go on to rupture. These pathologies get bad enough with patellofemoral joints. What's the end of it? Is it like,
I mean, it's surgery. Microfracture is kind of starting to be not as much of a surgical strategy at this point, especially for athletes. For a patellofemoral issue, you're likely looking at some kind of implant, a chondrocyte implant. There's a procedure called the Macy procedure that's common for this type of joint. And I think when you're having the Macy's, you got to have the conversation that if you truly want to be working and doing something in sports or requiring you to do some cutting and multi-directional activity, it's going to take a year and a half to 2 years with this surgery. And you're starting to see this with Alonzo Balls of the world. Like there should not really be a timeline put on any of these players. It's really how long does it take for this knee to start to accept load? And that implant is basically, they look at where the lesion is, they harvest this tissue, these chondrocytes, they look at it and they literally cut it out to what fits that scaffolding and they put it into that area. But again, patellofemoral is the hardest to come back from.
I think I was at that Vegas seminar where we met. I talked to Rich Willie a bit afterwards. I don't think I saw his talk, but I think he was bringing up Penny Hardaway. Didn't Penny Hardaway have bad knees and they did this microfracture thing?
He had a microfracture. Some of the greats had microfractures. It was very common. It wasn't like the meniscectomy, but it was pretty damn common for guys to get it because it was the new strategy. And most of them had to end their career after that. Greg Odom, Penny Hardaway, I think Jason Kidd had it. There's just a lot of players that got under the knife to get this thing fixed, and it just didn't respond.
And what was it worse back then, and it works better now, or what?
Oh, they're not choosing microfracture anymore. They're looking at cartilage preservation, harvesting their similar structure, and then trying to implant that into their knee versus taking a drill and just asking the body to do its own healing.
which it wouldn't do because it's not going to grow back that cartilage
It's
anyways.
going to be an inferior tissue.
Yeah. Yeah. Okay. Well, it helps that they got to learn that their own way. Penny Hardaway was
Yeah.
my favorite back in the day, way back in the day.
Eddie Jones was mine.
Eddie Jones, like
Lakers.
Miami Heat. Eddie Jones.
Yeah. Yeah. The guy that got traded for Kobe to play more.
Oh, okay.
Maybe that's why I like underdogs.
Was he? How good was he? Eddie Jones.
He was great.
Was there Eddie House too?
One of my favorites as well. ASU, long socks, instant offense, no defense.
Oh, okay. You got to clear this up a little bit more. Actually, you said it earlier. I have that meme of that Wojak guy putting he's clearly special. He's putting the square block into the round hole. He's trying to, and he's drooling. And I say tendons are dumb. Cartilage is more dumb. What exactly? I don't know if you've said it already. Go more into it. How is cartilage more dumb?
Cartilage is more dumb because it doesn't have any nerve endings. It's an inert tissue. It doesn't respond. It just is a sponge. Your true SpongeBob mean is cartilage. It is the loading and unloading, and the only way it can move micronutrients is through that mechanism. The cartilage breathes through the loading, unloading sequence.
Mm.
And when you sit for too long, and we call it the movie theater sign, you sit for 2 hours and you get up and you start walking like an old man, it's because there's not been a good transfer of fluid through your cartilage. And it starts to get engorged, and it wasn't able to kind of like do its cycling like it normally does. So that's why you start to limp, is because of this static position that it changes the fluid exchange.
Similar to the tendon. The tendon just,
Yeah.
I think, yeah. It just takes on, I think it just takes on water, being in like a slightly strained state from sitting.
Yep.
Yeah. Okay. I think this was a lot for the patellofemoral, but a lot of things I have not heard, and I know other people have not heard, because I think I've listened to every patellofemoral podcast I can find, and it's always very similar things of a lot of we don't knows and not that good of stuff.
Yeah. I mean, it's just more, if you don't have the research, you have to look at the structural lens of what cartilage does. And again, it takes on compression and it takes on shearing. And then I started working with athletes and started to find that velocity work first and then working pressure. Then I did my homework and I found a guy named Daniel Bernoulli. And then I read into fluid dynamics, and then I fell into Hagen-Pouzoual. And then I fell into Reynolds number, which is the turbulence of fluid and how it changes with pressure. And then I fell into Darcy's law. So that's kind of where I'm starting to get more of this theory, and how do we apply it in the weight room?
I think when we first talked, I had some patellofemoral. Why did it come about? Maybe just time off of basketball for many reasons, but yeah, I've been running this stuff you told me. I've given it to a lot of people too, and good results reported back.
Great.
And it helps too. I need to think of things. I need to conceptualize things, I need to have like an idea of what's going on instead of just like pain or no pain. I need to know like what's going on inside there. Even if it's wrong, I just want to have a picture of it, like SpongeBob.
I mean, I got like vodka bottles and hyaluronic acid, or Pepe Le Pew, and like those type of analogies are kind of what sit. I literally got a phone call the other day from individual on an NFL team, and he said, Guy had a nasty OCD lesion, and we did what you've kind of been preaching and what you do in your newsletters. And he goes, knock on wood, this guy's had no issues. So it's good to hear you and some others that are in this high professional setting that like these strategies actually work.
Mm-hmm. Yeah. Okay. I wanted to do this podcast when I told you need to create a resource for patellofemoral for the knuckleheads out there. So hopefully hopefully that will be done soon in the works, because I was complaining I have the patellofemoral or patellar tendon resource, and there's probably, I don't know, in a multiplication factor of how many people have patellofemoral, and they reach out to me, and I don't want to spend the time to DM everyone and explain things. So when you get this resource available,
Yeah.
I'll have to link it in the show notes if you ever get it done, because you have too many things you're doing. But I think there's enough practical takeaways here, things people can experiment for themselves.
I think, again, there is some subjectivity with each case, but there are strategies that individuals should start out with. I plan to create a program, and whenever that is, I'll tell you. And if you ever have anybody that needs it, just send them my way, and I can at least have a conversation with them.
Mm-hmm. Okay, you're always talking movies and music. So give me your top one, very top.
My favorite,
your top movie and top album.
So I am I'm a very dark person. I seem very nice and happy, and I'm from North Dakota, but maybe that's steered me into more darkness. But anything dark, I like dark humor. My favorite movie of all time is Requiem for a Dream, which is a drug movie. Have you ever seen it?
That's recent, isn't it? The last 10 years or so?
No.
It's old.
It's getting up there. Now it's old. It was probably 2010. So it's 15 years old now.
Oh, I think I have.
Jennifer Connelly, Jared Leto, Marlon Wayans, they start selling drugs, and then they get hooked on it, and their lives go into a spiral. Great soundtrack, great acting, great storyline. But most of the time people say I only can watch that movie once because it's so depressing. And ironically, that's my favorite movie. And album, dude, I am a huge Neil Young fan. Anything that Neil does, I listen to. I'm an old soul, so Harvest Moon is my favorite album. So yeah.
Wow. Okay. I thought you would struggle more with that, but you did it.
No, not at all.
Okay, tell everyone where to find you online, or
online. You can hit me on Rehab Code. So rehab_code. That's kind of where I produce most of my content. I do mentorship programs. I have a newsletter and a career codex if people are looking for jobs for professional sports in college settings. And then you can hit me on LinkedIn as well.
Perfect. All right, man. Thanks for coming on.
Yes.